Hello guys, this is me Dr. JK, and today we will discuss about adenomatoid odontogenic tumors. In our previous lectures we have discussed about ameloblastoma, calcifying epithelial odontogenic tumors, that is also known as the Pinberg tumor, and it was because you know that history of 1956. And then we have discussed about squamous odontogenic tumors, and today we'll discuss about adenomatoid odontogenic tumors. It comprises 3 to 7% of all odontogenic tumors, and it was previously known as the adenoameloblastoma. But its clinical features and biological behavior indicate that it is a separate entity. So then this was described as separate entity, and now it is known as adenomatoid odontogenic tumors. It is derived from the enamel organ epithelium, and investigators have also suggested that the lesion arises from the remnants of the dental lamina. Okay, if you talk about clinical features, then it is most commonly present in younger patients that are of 10 to 19 years of age, and it is uncommon in patients older than age 30. It is most commonly present in the anterior portion of the jaws, most commonly present in the maxilla, in fact 2 times more common in maxilla than mandible, and it is more commonly present in females. So if we talk about adenomatoid odontogenic tumors, then you should keep these points in your mind: young patients, anterior maxilla, and females. Here you can see it is present in the anterior part of the maxilla, and it comprises 53% of the total cases. And here it is also common in the, if you talk about mandible, then in the anterior portion. Most commonly it is present in the anterior part of the maxilla. Okay, so it is mostly they are smaller lesions, and they seldom exceed 3 cm in greatest diameter, although a few large lesions have been reported. There is another variant or form of adenomatoid odontogenic tumors, that is peripheral or extraosseous forms of the tumor are also encountered but are rare. Okay, these usually appear as a small sessile masses on the facial gingiva of the maxilla. So you know the difference between sessile and pedunculated masses. In sessile the base will be broader, whereas in the pedunculated lesions or masses there will be a stalk. The mass will be attached to a stalk, so the base will be narrower, but in sessile the base will be broader. Okay, so and it is similar to that of the gingival fibrous lesions. Okay, it is mostly asymptomatic, and it will be diagnosed on routine radiographic examination or when films are made to determine why a tooth has not erupted yet. Larger lesions cause a painless expansion of the bone, so it means the larger lesions can be there, but that will cause a painless expansion of the bone. Now we will discuss about radiographic features. There will be well circumscribed unilocular radiolucency that involves the crown of an erupted tooth, most often a canine. So whenever there is unilocular radiolucency present on the canine of maxilla, you may write down in differential diagnosis about the adenomatoid odontogenic tumors. And it is impossible to differentiate radiographically from the more common dentigerous cyst. So radiographically it is impossible. You cannot differentiate this dentigerous cyst and adenomatoid odontogenic tumor. But on the basis of this point, which I will tell you now, you can differentiate dentigerous cyst from adenomatoid odontogenic tumors. It extends apically along the root past the cemento-enamel junctions. This feature may help to distinguish an adenomatoid odontogenic tumors from a dentigerous cyst. Okay, so there is a difference between dentigerous cyst and adenomatoid odontogenic cyst, and that is dentigerous cyst will be attached to the tooth structure at the cemento-enamel junction here. But this the adenomatoid odontogenic tumor, they completely encircle the tooth, the crown, and the root as well. So this is the difference, and you can differentiate between dentigerous cyst and the adenomatoid odontogenic cysts. Okay, less often there will be a well delineated unilocular radiolucency that is not related to an unerupted tooth, but rather is located between the roots of the erupted teeth. This will be extra follicular type. This was the follicular type, and this will be extra follicular type. and they may be completely radiolucent, and often, however, it may contain snowflake calcification. This is one other characteristics of the adenomatoid odontogenic tumors. This feature may be helpful in differentiating the adenomatoid tumors from dentigerous cysts, this snowflake calcification. Here we can see it may also be present lateral to the these roots of the teeth, so it is difficult to differentiate it from the that of the lateral periodontal cyst. So if we talk about the DDs of this picture, we will say it may be on the first, it may be lateral periodontal, it may be adenomatoid odontogenic, it may be unicystic ameloblastoma. Okay, here you can see these are the snowflakes present here. You can see snowflakes. Okay, and yes, this was the extra follicular type which we have studied. The other one was this one was the follicular, and this one is the extrafollicular between the roots, and these are the snowflakes which you can see here. Okay, now we'll discuss about histopathological features. There will be a well-defined lesion, and that is usually surrounded by a thick fibrous capsule. Here you can see the capsule over here, the thick capsule here. Okay, alright, when the lesion is bisected, the central portion of the tumor may be essentially solid or may show varying degrees of cystic changes. Here you can see adenomatoid odontogenic cysts. These are smaller vegetations. This is nodular changes. These are changes of nodular tumor, or we can say nodular tumor formation. These are vegetation, smaller. So this is how it will encircle the tooth completely. This is the fibrous capsule. Okay, alright, spindle shaped epithelial cells that form the sheets, strands, or whorled masses of cells in a scant fibrous stroma. The epithelial cells may form rosette-like structures about a central space, which may be empty or contain small amount of eosinophilic material. So this rosette-like structure is characteristic of adenomatoid odontogenic tumor, and this material may stain for amyloid. Okay, so the epithelial cells may form rosette-like structure around the central space. Here you can see rosette-like structure around the central space. Here this is rosette-like. So these are the duct-like structures here, here, here. You can see here. These are columnar or cuboidal cells, and the nucleus will be away from the central cystic portion. So this is the rosette-like structure that is characteristic of adenomatoid odontogenic tumors. Here we are. So the tubular or duct-like structures, which are characteristic feature of the adenomatoid odontogenic tumors, may be prominent, scanty, or even absent in given lesions. These consist of a central space surrounded by a layer of columnar or cuboidal cells. This layer will be columnar or cuboidal cells. Okay, the nuclei of these cells tend to be polarized away from the central space, which I have mentioned. Not true ducts. These ducts will be not true ducts, and no glandular elements are present in the tumor. Small foci of calcification may also be scattered, which give that snowflake appearance to the tumor. Okay, if you talk about treatment and prognosis, then it is a completely benign because of its capsule. Remember, the difference between a benign and malignant lesion is the capsule. If the capsule is there, then it means there will be benign lesion. It enucleates easily from the bone, so enucleation will be the treatment of choice for adenomatoid odontogenic tumors. Aggressive behavior has not been documented, and recurrence after enucleation seldom, if ever, occurs. So this is it about adenomatoid odontogenic tumor. These are the references of this lecture. Hopefully you enjoyed my lecture. If you enjoyed my lecture, please subscribe to my channel, and we will come up with more videos on oral pathology. So till my next lecture, take care and bye bye.